Go.
Okay. Nishant, you're around?
Yes, ma'am. Yes.
And you start off with the
Good,
introductions. Yeah.
good evening, delegates and participants. Thank you for joining Shield Connect. The Society for Maternal Fetal Medicine India presents you with the virtual learning series on pre-eclampsia, Series 5, VLSPE 2022-2023. And now, let me introduce Dr. Anu Joseph, ma'am. Ma'am is a consultant and medical director in Trinity Healthcare Clinic in Electronic City. Ma'am is obstetrician and gynecologist, fetal medicine consultant at Kaveri Hospital in Ma Kaveri Unit, Electronic City, Mangalore, and visiting consultant of fetal medicine. And ma'am is the EC member of SMFMI and event coordinator of this series. So I hand over the session to Dr. Anu Joseph, ma'am. Thank you, ma'am.
Thank you, Nishant. Warm welcome to all of you. We are here on the 5th series of virtual learning on preeclampsia. I would initially like to introduce all of you to our speakers for today. Sahiti, if you would put up the rest of the faculty CVs, please. First of all, I would like to introduce our mentor and our guiding light, Dr. Prakash Mehta, sir. Sir is the Chief of Maternal Fetal Medicine at Mahavir Jain Hospital. Sir is also our President for the Society of Maternal Fetal Medicine India, and he's a co-chair for the Pre-eclampsia Education of the Nation program, which we are all a part of it today. Sir is also the organizing president for the upcoming iShip conference, which should be held in September 2023 in Bangalore. And sir has been a great teacher for all of us. And to people who are probably hearing him today, also every program of ours, he becomes a teacher for newer students from all around the world. I would like to next invite Dr. Sarosh Rana amidst us. Madam has been a force behind running, starting and pursuing the PENAI programs and anything and everything related to the hypertension part of the program. She is a ardent favorite of hypertension in pregnancy, and Madam is the section chief of maternal fetal medicine and professor of OBG in University of Chicago, USA. She is also the international co-chair for ISHP, and she is the international advisor for the SFMI. Madam would be with us, I hope, for the entire program, giving us her insights into preeclampsia in the postpartum period. Next, I would like to invite Dr. Revati. Dr. Revati is the stepping stone into Preeclampsia Education of the Nation program and the entire preeclampsia programs that we are doing as a part of SFMI. Like Dr. Sarosh Rana, Dr. Revati is also anything and everything you talk to, you can hear preeclampsia in it if Dr. Revati is around. She is the chief consultant at the clinic Mirror Health and the managing director there, also visiting consultant in Milan, and our secretary to the Society of Maternal Fetal Medicine India. Dr. Revati is the co-chair for Preeclampsia Education of the Nation and the secretary and the organizing secretary for iShip World Congress 2023. Areas of interest is obviously hypertensive disorders in pregnancy, with particular interest in preeclampsia and in utero programming. Coming next to our speaker, the first speaker for today, Dr. Hema Priya. Dr. Hema Priya is associate professor at JSS Medical College and Hospital in Mysore. Dr. Hema is a very well-spoken person and very, very ardent speaker. Special interest are in endoscopy and high-risk pregnancy. We got to know each other through the SFMI project when SFMI started spreading its wings, and then we started its first chapter in Mysore. She is a member of SFMI through the Mysore chapter. Welcome, Dr. Hema Priya. Dr. Ramni, ma'am, you have joined?
Yes.
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 Yes, Madam is a very great academician. She has been a member of most of the OG associations, be it the FOXY, be it the ICOG, be it the programs for smaller units like Tamil Nadu and etc. etc. She has been a great OGian from the time that she is in the PG and UG program, with lots of gold medals and lots of accolades from in her. Welcome to you, ma'am. Dr. Jyoti, I think ma'am is not yet joined, but she'll be joining soon. She's a professor and HOD of Government Medical College, Kozhikode. And whenever I hear this word, Medical College, Kozhikode, it's a place with teeming with the number of OG cases. I mean, we had seniors. I've never been to Medical College, Kozhikode, but we had friends from there, and they were like, 1 month, 2 months, 6 months of OG in Kozhikode Medical College is enough and more when compared to the 3 years of MS we do anywhere else. So with that much of information and that much of experience, doctor is joining us. Welcome to you, Dr. Jyoti. Dr. Shiny ma'am, with a pleasant smile. Ma'am is professor at, previously professor at CMC Vellore, Ludhiana, and thereafter she is working as a senior consultant in Bangalore Baptist Hospital. I'm meeting ma'am for the first time. I hope ma'am's great accolades from CMC as well as Baptist Hospital brings us great insight into the pre-eclampsia. Welcome to you, ma'am. Dr. Swati, she is the resident post-fellowship in BMJ, Mahavir Jain Hospital. Dr. Swati has just finished her fellowship in FMF, and she is pursuing her career as a FMF consultant now. Welcome to Dr. Swati. Now I hand over the mic to Dr. Prakash Mehta sir for his welcome address, followed by Dr. Sarosh Rana for her welcome address to the gathering.
Good morning, everyone. It's a pleasure to be on this program. The Society of Maternal-Fetal Medicine had started up in a very small way, roughly about 5 years back, and today we are going great guns, I should say. We will be arranging the iShip Conference World Congress 2023 in Bengaluru. We already have a few chapters in various parts of the country from the SMFMI, and we have been doing this pre-eclampsia learning program for the last 1 year. And I'm very happy to say that not only from all over across India, but from various countries across the world, we have people taking up this course. You need 75% to pass in your exam, passing that exam and getting certified. We are hoping that through this society, we make at least some kind of an improvement in the pregnancy care that our women get. Also, in every program of VLS PE that we have been having, it has been our endeavor to encourage youngsters to be a part of the program. Definitely, if any one of you who are there with us on this Zoom meeting and many, many more who are watching this being live streamed on Facebook, I would say that if you are interested to participate in any of our programs as a faculty, please do write to the office. And we have taken the cudgels to see that the youngsters get a good platform, youngsters get an idea to put forth their things. So most of our programs will have a good mixture of the seniors. You saw we have Dr. Ramani with us with such a vast experience, Dr. Jyoti from a very busy medical college, as Dr. Anu put it, and we have a youngster like Dr. Swati. That is the basic motto of our society, that we encourage the youngsters. I would also, before we start the program, request you all to join us for the ISSHP 2023 World Congress. Please do join. The early bird registrations will stop by March 31st. More than registration, I would be more interested if you could send in your papers, because you have a chance to speak in a World Congress. and the certificate that you get would be an excellent on your biodata. This is the first time that the Congress is coming to, I would say, to the developing Asia, because it has been in Japan before, but Japan is almost a Western country. So in the rest of the Asia, this is the first time we are having this program. So please do join, because if you have to go abroad, let's say you got to go to France or Canada or US for a program, it really costs you a lot of money. So it is there in our backyard. Please do join the program, and please do present the paper. We do a lot of work in India. We have the maximum number of patients I can think of, but we are not publishing papers. We are not showcasing ourselves. Possibly because we are very busy in our practice, we don't have time to sit down and write papers. Let us change it. Let the world know that we are doing a lot of work. So I would request all of you to present the papers. March 31st is the last date. It's only the abstract. Even if your abstract is ready, you can send it across. It will be sent to a national reviewer. It will be sent to an international reviewer. And once it is accepted, you will be given a chance to present your paper in the iShip World Congress. So with this, I revert back to Dr. Anu. Thank you for all your introduction, and thank you for being an anchor of this program. This is the fifth in the series that we are having. And after this series is completed, we are going to start on the next topic and other series, because we take up a topic and have a great discussion over it for a period of almost 12 hours in various sessions. So please do join us for our future programs, and do join us for a iShip World Congress, because you're going to have who's who from the world in that Congress. Of course, Dr. Sarosh Rana is the driving force behind it, but we will be also having Dr. Laura Maggie, Dr. Peter, Dr. Annie, and all the other luminaries from various parts of the world coming in. And we are going to have a lot of new topics in this iShip World Congress, including topics like artificial intelligence and pre-eclampsia. So it will be very good for youngsters to do something about it. So thank you, Anu, and please proceed further.
Dr. Sarosh Rana, welcoming you for the inaugural address.
Yeah, thank you. I would kind of follow what Dr. Mehta was saying. So maybe two things is, one is, I agree. The PENAI course has been really great. I think perhaps, we can talk offline, but maybe we can update some of the contents, Revati, because there have been some new papers. So we should definitely look at that. I don't know how long we've been running this now. PENAI has been running for 2 years.
Yes.
Yeah, so maybe every 3 years we should look at the course content to make sure that what we said is actually still like holds and is true. And then the other thing I had a suggestion is that I agree with that. I think, like I said before in the previous session, this is just the beginning. So I'm hoping that it'll inspire people to say, hey, you know what? I learned some stuff, that's fine. I got my certificate, that's fine. But let's just continue to do some sort of a continuous kind of education, even at every 6 months or every 1 year. I tell this to my residents all the time, and everybody. I was like, every night before you sleep, just read something, even if it's 1 page. Pick up an article, read 1 page. You will be 1 page more knowledgeable the next day than you were the previous day. So as long as we are all learning through whatever, this is good learning forums. It's very safe. You can say anything. You can bring up anything. People say, sure, this is what I do. This is what you do. This is very, very safe environment. The other thing is obviously iShip is a big deal right now for us, for all of us. And thanks to Dr. Mehta and Revati for putting in so much effort. So we are trying really hard. We've been working for so long now. We have lots of meetings, and we'll have lots of people, hopefully international people coming. And I agree. Even if you have like a small idea, just an abstract, nobody's going to come after you and say, hey, you published this abstract, you didn't really convert it into a paper. Nobody's going to ask you that. And I think it's a great forum to meet with people and just meet with each other in person. It's happening in person. We haven't been in person for so long. And yeah, it hasn't been to any country in that region, except for, I agree, it was in Japan. So I think it's a great opportunity for people to come out and just there's so many things we can learn from each other. So you guys are doing so many things that are obviously clinically and otherwise, perhaps different. And it's, different is good. So I think it's a good forum to meet. Me and Revati actually met in one of the iShip meetings. So not that I'm going to butter myself out to, mentor more people, but perhaps you find other people. There'll be so many people there that you can, help each other and then do maybe studies together. There's always some fun to be with people who are equally motivated in terms of just like pushing it forward. So I would say this is great. You guys are doing a great job. And then I'm just quite fortunate actually to be part of the group. So yeah, welcome.
Thank you so much, ma'am. Now I invite Dr. Hema Priya. Madam Dr. Hema Priya, please do share your screen and start with your talk on postpartum hypertension and preeclampsia.
Good morning, everyone. It is really an honor to be part of this VLS series. And today I will be talking on postpartum preeclampsia. So before I start, I would say that with the inspiration of Dr. Prakash and Dr. Revati, we have started a chapter in Mysore, and we're hosting the first PENAI on-site program on February 19th. And we have got a really overwhelming response. We have actually closed the registrations since we have to restrict it to 50, but a lot of other people are asking us. So there is a lot of interest in preeclampsia being generated everywhere. So now, since we're short of time, I'll just go to the topic. So usually it is the conventional saying that delivery cures preeclampsia, but it is not so. And the postpartum lady is still at risk of developing a lot of complications. So today we will just be defining what is the postpartum hypertension, what are the immediate risks, and what are the long-term implications. So if the blood pressure persisting more than 140/90 after delivery, generally immediately post-delivery, the blood pressure tends to come down, but then again it rises after 3 to 6 days. So that is the time when we have to be very, very careful. Majority of the patients, especially low-risk patients, we do discharge them within 48 to 72 hours. So we have to be really careful, as this postpartum preeclampsia can present even for the first time after delivery. The patient need not have a history of hypertension or preeclampsia. They can also have the first symptoms soon after delivery, and usually it is after 72 hours. So for patients who are known preeclamptics, delivery is just the acute treatment. It is not a cure. And it is not actually, people don't have really long-term, really good data, because patients do go home and BP monitoring is not very, very prompt in postpartum women. So there have been prevalences reported from 0.3 to even up to 27%. And complications can present even in the late postpartum period. Not only, it's usually within the first week, but then even in the late postpartum period, de novo eclampsia and HELP syndrome have been reported. So ACOG defines something as the 4th trimester care gap, where usually once we discharge the patient, we do not see her till 6 weeks. We generally traditionally call the patient after 6 weeks. So this is the time when problems can develop. So what the ACOG recommends is, especially patients who are known hypertensives, you call them three days later, or 3 days after you discharge them, you call them and review them once again, their blood pressure and the medications what they're taking, and explain to them the warning symptoms which should cause them to report immediately. Even the Canadian guidelines recommend monitoring BP 3 to 6 days postpartum, and they have given a list of various drugs which can be safely used to treat preeclampsia during lactation period. So this is a sort of patient education pamphlet given by the Preeclampsia Foundation, and they also have certain bracelets like which you can give to your patients, that the patient is known preeclampsia and she is still at risk. So it is both like a sort of education to the patient, awareness building to the patient that she is still at risk, and once she has delivered, everything is not fine. She still needs to be followed up, as well as a sort of reminder to the doctor to examine the patient more carefully. So the risks which the patient can have, yes, she is at a risk of postpartum eclampsia, multiple organ damage, stroke especially, and these are the warning signs that we should educate the patient that if she has any of these warning signs, she should report immediately. So which are the patients who are at risk for postpartum preeclampsia? Definitely those who have had it in the antenatal period, a history of gestational hypertension or preeclampsia, with or without severe features. Sometimes if they do not have preeclampsia, but patients with obesity, multiple pregnancies, these are the patients who are at risk. And even those with preeclampsia, especially depending on the requirement of antihypertensives during pregnancy. Those who require a higher dose are more at risk in the postpartum period of developing complications. And again, those with chronic hypertensives or any secondary causes of hypertension, again, they can develop problems during the postpartum period. So this was a study conducted in 2019 where they wanted to determine who are the patients who are at higher risk during the postpartum period. So they divided patients with early onset and late onset preeclampsia, and they classified various characteristics. This was a retrospective study where they took a 5-year data, and these were the things they found, that the antepartum characteristics who had a higher mean blood pressure, those who had symptoms of preeclampsia and early onset preeclampsia, the gestational age being less than 34 weeks, those who had a small for gestational age fetus, these are the patients who were more prone to develop complications in the postpartum period, and they also needed higher doses of antihypertensives in the postpartum period. Similarly, the antepartum characteristics, where those who had a preterm delivery, those who required magnesium sulfate, those who underwent a cesarean delivery. The postpartum characteristics, immediate postpartum, again, they had a higher mean blood pressure, and those who had imminent symptoms in the immediate postpartum period. These were the patients who were likely to develop complications and those who required antihypertensives in the postpartum period. So the immediate threat soon after delivery, yes, postpartum eclampsia, pulmonary edema, stroke, thromboembolism, and HELP syndrome, which can develop immediate postpartum, or they can even develop in the late postpartum. Now, once the patient goes home, stroke always need not manifest as a classical hemiparesis or a paralysis. Certain even subtle signs like dizziness, loss of balance, change in vision, some numbness in the face or some tingling sensation, slurring of speech. So all these are the things which we should educate the patient that even these subtle signs, she should report immediately. And she has to know like at what time the symptoms have started so that we can initiate early treatment and probably prevent a major catastrophe from occurring. Again, these are the various factors which can sometimes mimic preeclampsia in the immediate postpartum period. Certain things like volume overload or certain drugs like your methyl ergometrin, all these things, ephedrine, vasoconstrictors, which we use sometimes even to probably prevent or manage PPH. Those things also can present with symptoms similar to preeclampsia, leading to headaches, nausea, vomiting, sometimes even seizures, or may have a transient rise in blood pressure. So we have to rule out any other spurious other causes which may lead to a transient rise in blood pressure. And then also we have to, if the blood pressure is persistently high, then we have to think of other secondary causes of hypertension probably, which may not have been detected in pregnancy. And probably the symptoms are manifesting either for the first time in the postpartum period or pregnancy. We have treated her as preeclampsia, but because of persistently very high BP recordings, we have to think of the secondary causes like pre-existing renal disease, hyperthyroidism, pheochromocytoma. All these things we have to rule out. So in the postpartum period, generally the antihypertensives, yes, labetalol, nifedipine, what we are using as the first line drugs can be continued. We can add longer acting drugs like amlodipine. Beta blockers, yes, they can be used in the postpartum period. AC inhibitors can be used. Generally, we do not give methyl dopa. Usually after 48 hours, it carries a risk of postpartum depression. Angiotensin receptor blockers are not indicated in the lactating period. Diuretics, may affect lactation, but if at all it is needed, really needed to help the edema to clear out, maybe a short-term course of diuretics. Hydralazine, IV labetalol, again, can be used for hypertensive emergencies. But these are the two things which we generally avoid in the lactating period are angiotensin receptor blockers and methyl dopa. ACE inhibitors are considered to be really good drugs, and especially in patients with associated cardiac disorders, peripartum cardiomyopathy, ACE inhibitors really help. So how to evaluate this patient? If she has only hypertensive, then probably if she's responding to the drugs, there is no other investigation needed. If her blood pressure is getting controlled, it is purely pre-eclampsia and she's responding to your antihypertensives, you need not do any other further evaluation for secondary causes, at least up to the 12-week period, and if her BP normalizes after that. But if at all she's not responding to your treatment, then we should look for secondary causes. And if she has any other symptoms like cardiac failure, palpitations, tachycardia, we should do a complete cardiac evaluation, look for causes like thyrotoxicosis, pheochromocytoma. If she has convulsions, she's responding to your magnesium sulfate, good. If she's not responding, then probably we have to look for any other neurological causes, probably do a CT or an MRI. HELP syndrome again can present de novo in the postpartum period. It may mimic HELP, or it may be some other cause like hemolytic uremic syndrome, acute fatty liver of pregnancy. So depending on the response, we individualize the management and do further investigations as and when needed. Coming to planning the future pregnancies, we do definitely have to explain to her that there is always a risk of recurrence and what can we do to prevent this recurrence. Periconceptional aspirin is the one which we are routinely following. Other supplements, high dose calcium, antioxidants, vitamin D, there are, I'm not going into the details of all those things. Whether we can predict preeclampsia in the future pregnancy is again another question mark. There are a lot of markers, a lot of studies which are going on for that. So we do have to explain to the patient that what are the probabilities that which we can help to predict in the future pregnancy. Coming to the long-term complications or the late complications, yes, she is definitely at a risk of developing chronic hypertension. So we should ask her to have annual health checks and regular BP checks, either by home BP monitoring or monitoring near at a clinic close to her house. Cardiovascular disease, it is said that probably preeclampsia can be a transient warning sign. It's a sort of a warning given to the patient that she may develop cardiovascular disease in the future. So if she can adopt a healthy lifestyle, probably we can treat it as a sort of, getting a warning so that we can start primary prevention for developing future cardiovascular disease. And especially women who have early onset preeclampsia or those who have a SGA fetus are at a higher risk for developing cardiovascular disease in the future. Same thing with metabolic syndrome. There have been various studies as to which are the patients who are more prone for developing this. Again, incidence of metabolic syndrome is associated more with women who have had early onset preeclampsia in combination with a small for gestational age fetus. And also, there is a risk of elevated your highly sensitive C-reactive protein again if the CRP levels are high in the postpartum period. Again, those are the women who are at really high risk of developing metabolic syndrome, and probably those women can be advised the preventive strategies. So as such, there is not really much in terms of drug therapy, medication therapy, what you can do. But again, this is a time to reinforce the woman to have an active lifestyle and a healthy diet, which is the only thing which we can assure her that probably her risk for developing future complications and developing preeclampsia during the next pregnancy will be lower. Thank you. If there are any questions or any doubts.
I have a question. just by show of hands, and thanks Anu for the, sorry, I said Anu. Thanks Emma Priya for a great presentation. I have a question, just by the show of hands, how many people have a program for management of postpartum hypertension? Like how many people are systematically approaching this in your practices? You do it in every patient every single day. Do a lot of people have translated this into your practice? Yeah, and that's like, you'll be surprised. I see some heads shaking. It's not even practiced here in the US. So even when I looked in my hospital several years ago, they didn't have any systematic program for management of postpartum hypertension. I think as good as we are, we kind of, because it really does require a lot of effort. So I know I've talked about this, Revati, before, but we actually created a program here, and it's all published. It's in Green Journal. And initially, we just started out with some of those pamphlets that you were showing from the Preeclampsia Foundation. And if you allow me to share my screen, I can show you this kind of, we created a video. We started giving patients these pamphlets. Then we started making their appointments. Then we started giving them these little bracelets. Then we give them a blood pressure monitor. And then it kind of literally like caught on. We've enrolled at least like in the past 4 years, about 4,000 patients through this program. And now, because it's been so successful, I actually got a couple of awards from the Health and Human Services as an innovation in tech. And it's nothing innovative. I just literally handed out blood pressure cuff to patients and told them, check your blood pressure. We have to create a system of who do they call? What do you do with the blood pressure measurement? So now we are actually doing remote patient monitoring. We have a 24/7 connected, following your flow chart is really, so it's really helps, because I can tell you, and maybe Revati, I don't know, you probably have that Green Journal paper, but I put all those flowcharts in the supplement, so you can actually download it, and you don't have to exactly follow what's in there, but it's just like big picture. And I printed those flowcharts for our residents. They put it in labor and delivery. That's all available on your computer intranet, so you can manage patients. And then, readmissions, everybody goes to the MFM service. How do you treat their blood pressure? Who do you consult? What do you do? When do you discharge them? When do you call them back? What do you do when they're calling back? When they come back for postpartum hypertension visit, how do you manage their blood pressures up until 6 weeks? And that is like really, really standardized our care here, because we are in a large institution where we have several physicians and residents and different kinds of people. So I would highly recommend you, just
Ma'am,
read
can
that.
you, a few people are asking, can you share the screen of your flow chart of events?
Sure. So let me just do this. Give me a second. Maybe somebody else can talk while I pull this up, because I wasn't planning to show it. But give me, it says it's built in our PENAI program.
PENAI program.
Oh, very good then. Yeah, so that's actually a good thing. But I can show you like one slide, not just this thing, but yeah, if it's in the PENAI program, I don't know if there's a way you can, what I did was I sat down and I said, okay, what should we do? And you can just create it in your system, like what helps you. And
We can
not
email everyone, Dr. Sarosh. What we can do is we can send that to everyone.
On the chat box.
Yes, for all the attendees, we will send it on the email. You can just put that slide onto the chat box, or we'll take it from the PENAI program.
Keep going.
Yeah, I would tend to agree with it, because most of my referrals in the postpartum period, when you look at them with severe pre-eclampsia or other complications they come with, it is very obvious that a small care in the postpartum period could have avoided it. But unfortunately, all of us tend to relax once the patient is delivered. It has been drilled into us, I would say, from time immemorial, that once the patient delivers, she's going to be fine, which is definitely not true. So I'm sure Dr. Sarosh would give the charts to everybody on the chat box, or if she sends this to us on the mail also, we'll share it with everybody. It is there in the PENAI program. Whatever, do something for your postpartum patients. You may not be able to do the complete gamut, but at least something. That will save not only your patient, it will save you also from litigation quite often. So let us follow our postpartum patients, in a very systematic way. Yes, Dr. Anu, you could go ahead now.
Thank you, sir. Thank you, Dr. Sarosh Rana, and sir. Thank you, Dr. Hema. Next, I would like to move on to our panel discussion, which is on the panel discussion. I would invite Dr. Prakash Mehta to be the moderator. Sir would lead the panel for preeclampsia with severe features, complications, and their outcomes.
Yeah, once again, good morning.
To join on to the panel, I invite Dr. Ramni Devi, Dr. Jyoti Ramesh, and Dr. Shaini Verghese, Dr. Swati Pai.
Yeah, good morning, everybody, once more. And this panel is going to consider the complications, the outcomes, and of course, I'm going to re-include the postpartum care as some of the questions to our panelists. To be with me on this panel, we have a wonderful group of people, Dr. Ramni Devi, Dr. Jyoti Chandra, Dr. Shaini Verghese, Dr. Swati Pai, all well experienced in the management of pre-eclampsia. Swati may be a youngster, but she has got enough experience in pre-eclampsia. And I extend once more to all the youngsters listening to this program that if you would like to join our program as a member of the program, you're most welcome to write to the office, and we'll make sure that you are included in the group. So sometimes in life, everything goes smoothly, and sometimes unexpected happens. When you least expect, that is when it happens. Now we know that preeclampsia is a multi-system heterogeneous disorder. The pathogenesis, we are still not very sure. It has got an unpredictable course, devastating outcome if missed, uncertainty which mandates delivery because you don't know what's going to happen to the patient. So you play the safest route and deliver her off, whether it's preterm or whatever. And it's a partially preventable condition. We have got a lot of drugs, aspirin and whatnot, but it's only partially preventable. Many maternal and fetal deaths or near misses are associated with substandard care. So possibly with our inputs from our expert panelists, I hope to make a dent on this. With this, we go to the first case. This is a 26-year-old gravida 2 paravan living 0. Referred to me at 31 weeks. She has a past history of severe preeclampsia and IUD due to abruptio placenta. Now, when she came this time, her previous blood pressure readings were said to be normal. Current examination in a nursing home where she was booked. She was found to have a BP suddenly of 190 by 130 millimeters of mercury. She had 3 weeks FGR on clinical examination. There was a history of headache. Edema was present. And reflexes were all exaggerated. She was given in that place injection magnesium sulfate 4 grams start dose and capsule nifedipine 5 milligrams sublingual, and then referred to me. The first question goes to Dr. Ramani. What is your opinion on sublingual nifedipine?
Good morning, everybody. Thanks for the opportunity. See, earlier, sublingual nifedipine was given when I was a postgraduate, and we came across a lot of complications. There were sudden fetal IUDs happening, and that there were sudden hypotension. Probably that was the reason for sudden IUD. And after that, we had almost stopped using the sublingual nifedipine. We were not supposed to use. I think there are certain pitfalls in this particular patient. First thing is, we should have evaluated her because with the previous history of abruptio placentae, probably due to severe preeclampsia, she should have been screened or at least followed up during the inter-pregnancy period. Or if she has failed to come, at least the primary consultant should have evaluated her during the first trimester. And probably she is the ideal candidate for starting a low dose or a baby aspirin. So this is my take home. There is no role for sublingual nifedipine in severe hypertension.
Absolutely, very rightly put in. But unfortunately, patients keep coming in spite of whatever we do. I have discussed this topic in many conferences, and I try to include it in my every pre-eclampsia talk, but still people are using it. Possibly they saw a blood pressure of 190 by 130, got so scared, and without realizing that the time lag which occurs between the ingestion of the tablet and the effect between sublingual and oral is not too great. That may take a minute or two. This takes about 5 to 10 minutes. So let us take a vow that we will never use sublingual nifedipine. Next question to Dr. Jyoti. She has come in now. What investigations will you order?
Thank you, Dr. Prakash, for involving me in this panel. We understand that this patient had a previous abruption and previous stillbirth. So ideally, as Dr. Ramani said, she should have undergone a pre-eclampsia screening at 11 to 14 weeks. Anyway, we don't know whether it is missed. And if she has come now, we have to find out what is the changes with hypertension has produced in her. So we have to look at all the end organs, like we have to do a fundus examination, we have to do a liver function test, a renal function test, her complete blood count for platelets, uric acid, proteinuria. So these all blood tests need to be done to find out her end organ evaluation. And I would also suggest an APLA testing because she has a previous IUD, previous abruption.
Yes.
And APLA testing would also be justified in this patient. It should have been done earlier, but now can be done.
Thank you. But what just I wanted to emphasize one point is that 12% of the patients with severe preeclampsia may not show you proteinuria. So
True.
please be careful about that. Just because there is no protein, do not ignore the patient. Okay, we have covered all these investigations. Okay. The next question goes to Dr. Verghese.
Yes.
This patient has a hemoglobin of 11.6 grams per cent and a PCV of 47.2. Do you routinely order PCV with the HP percent? Because I've seen any number of cases where only HP percent is done and the PCV is not ordered. So would you order, and what is its importance?
I think a complete blood count should be done, sir, because there's just a hemoglobin would not give you any, picture of the patient, because in a severe preeclampsia patient, the hematocrit gives us a lot of information because there is hemoconcentration that is there. And because of that, you will see that the PCV would definitely be very, very high. And it would not be like a normal patient where it is 3 times the value. It may be much higher than a normal patient, where a normal patient, a hemoglobin is 10 and the PCV is 30. So in a severe PE, you might find that the packed cell volume is very, very high. So it's very important to do the complete blood count, which of course includes even a PCV.
Yeah, so Dr. Shaini has made that point very, very clear. And then we go to the next question. In this patient, uric acid estimation was not done in the previous referring hospital. On admission, we found that it was 8.5. Do you feel this is important? And what is the exact role of uric acid estimation? This question goes to Dr. Swati Pai. Swati?
Thank you very much, sir, for giving me this opportunity. Yes, uric acid does have a role, mainly because in pregnancy, what we see is the glomerular filtration rate and also does the plasma flow to the kidney increases. On the other hand, is also proteinuria, which is seen in the pre-eclamptic function, pre-eclamptic patients, and moreover, the renal functions also get impaired. Often the changes are biphasic. First, that there's a tubular dysfunction, and later there would be a glomerular dysfunction. So a common early feature is reduced uric acid clearance, reflecting altered tubular function, thus causing a reciprocal rise also in the plasma urea. So therefore, there is definitely a role of uric acid estimation in pre-eclamptic patients.
Okay, would you use it to deliver your patient? Or it is just to understand that, yes, we are dealing with something, a serious disorder? Dr. Ramani, you're muted. You could add on if you wish. You're muted, please.
Yeah. Sir, I think uric acid has got a role to say that this particular patient has got severe pre-eclampsia. But I won't take it as a point to state that just a simple elevation of uric acid, we have to decide upon the delivery of the patient. It is a warning. It's a warning for the consultant to plan earlier management, proper management.
I think just put in the right perspective. Thank you, Dr. Ramani. The next question comes to you again.
Yeah.
Now, in this patient, LDH was not done in the referring hospital. We always say we have to do a liver function test. And unfortunately, in most of the hospitals, when you say liver function test, LDH is not included. So even in this hospital, it was missed. But when we did it in our place, I found a value of 1,240 units. Do you think this is significant?
Yes,
and
sir.
LDH as an investigation to all your pre-eclampsia patients?
Yeah, see, like this particular LDH value of 1,240 is very significant because probably she is going for a HELP syndrome. Okay, so that so simultaneously we have to do the platelet count and all the other things, SUOT, SGPT, and find out and correlate all the three to put in whether she is a likely candidate for a HELP syndrome. See, routinely we don't do LDH, but in cases with severe pre-eclampsia, like this particular patient where she is having a diastolic PP of 130, yes, definitely I will go for the LDH evaluation.
Thank you. So the management would include putting a PET chart for her, which records the fluid input-output, blood pressure, CVP, oxygen saturation, reflexes, urine albumin, weight gain, everything is charted. You should be charting on the paper. And the cause of this patient in view of a previous history and current severe pre-eclampsia with FGR and a non-reactive NST and emergency LSCF was done. A 1.14 female baby with good APGA was born. The further course was uneventful in both the mother and the baby was also discharged in a stable condition.
Good.
The next question goes to Dr. Jyoti. We find that sometimes when you do on a pre-eclampsia patient, even slightly more than normal blood loss at the time of delivery, causes problems. So is blood loss, why is blood loss at delivery very important in pre-eclampsia patients?
Thank you, sir. Before I answer this question, I just want to put 2 points in management of the patient. It was mentioned that a cesarean section was done at 31 weeks. In our institution, we give anyway, magnesium sulfate would have been given to her. So that's helpful for neuroprotection, less than 32 weeks.
That was done, ma'am. That was done.
Okay. And steroid administration would also should be done for a preterm birth to prevent respiratory distress syndrome. Another thing is we had studies on LDH and we found that those having an elevated LDH, as madam pointed out, go for HELP syndrome. So they have to be under observation. And elevated PCV is also important because such patients may develop thrombosis and postpartum, they need to have a thromboprophylaxis. So that PCV also should be done routinely. And we know that blood loss at delivery is very important because these women with hypertension have got a retracted blood volume. Their blood volume does not rise to the extent a normal woman would have. So such women may go into shock with very low blood loss. So that is very important that we prevent blood loss by active management of third stage of labor in such women and also monitor them by shock index because they can go into shock very fast. Even with
wonderfully put, Dr. Jyoti. Thank you. So it is already covered, but only one point is that if there is a blood loss occurring, don't use ergometrin in these patients. I know it looks very simple and very silly to point this out, but I have seen ergometrin being used on this patient. Remember that in some of your patients, when you give ergometrin, the blood pressure is going to shoot through the sky. So please be careful about it. And we got wonderful drugs to uterotonics now. We don't really have to use methogen anymore. With this, we go to the next case. A 25-year-old primary gravida referred with 28 weeks of gestation, well booked. She has had at least 6 scans during her pregnancy. She had an edema for the last few days. She came with epigastric pain to that place and she was treated with antacids for 2 days. Did not improve. So that afternoon she was admitted. The BP was found to be only 140 by 90. So the doctor just repeated the injection pan again. At 11 p.m., she had convulsion. She was catheterized, and then they did all the tests. There was hematuria, and the platelet count was 46,000. They gave injection magnesium sulfate 4 gram IV plus 10 grams IM at a platelet count of 46,000 and transferred her at 1 a.m. to my center. On examination, her general condition was unsatisfactory, confused, but she was not pale. Edema was present, pulse was 118 per minute, blood pressure was 150 by 110. The uterus was corresponding to 26 week size at 28 weeks of gestation. It was well relaxed. The FHS was 158. The catheter, the tube was empty because I put the catheter in the nursing home. The tube was empty and there was 20 ml of frank blood in the bag. So on admission, the more important investigations were that the INR was 1.49, the liver enzymes were elevated, maternal kidney showed grade 2 nephropathy, gallbladder was thick, ascites was present, and there was minimal pleural and pericardial effusion. Well, we had to take a decision to deliver her. We delivered her post-operative. She had PPH. In spite of all transfusions, she had bleeding from the incision site and the urine refused to come out, and whatever few drops that were coming was like a frank blood. Now, next question goes to Dr. Shaini. Now, this patient had epigastric pain for 2 days. How will you evaluate a pregnant patient who complains of epigastric pain? Dr. Shaini?
Yeah, thank you, sir, for that case. And it's an eye-opener because sometimes we do see such complicated patients in our practice, and epigastric pain can be an alarming sign. And sometimes such cases are the patients who teach us from our mistakes, because epigastric pain is a sign which should not be ignored in any pregnant woman at whatever period of gestation, especially after second trimester, even sometimes maybe in second trimester, because that could be an early sign that the patient is going into health. And most often it is due to subcapsular hemorrhage or the Glisson's capsule distending and causing pain. And we ignore it as a gastritis of pregnancy and maybe give her an antacid, and the patient comes back just like you told us, you know. And it's a very sad scene that this patient came back with such a deteriorating condition, you know, with just ignoring an epigastric pain. So that is a very important sign when patient says, and it's just palpating the right hypochondrium itself will tell us, because patient can have severe tenderness.
Thank you for bringing the point out. 2 precious days were lost in this patient, which possibly would have made a difference between life and death. Okay, next question to Swati. How do you control severe hypertension? Swati?
Yes, sir. Severe hypertension basically would require IV antihypertensives, mainly labetalol, which is most commonly used even in our setup, and we give it as bolus doses rather than infusions. Both are preferred methods. Even hydrolazine is a second, and even nifedipine can be preferred. What is seen in labetalol is it's contraindicated in women with asthma or decompensated cardiac function or more than first degree of heart block, or else if they have severe bradycardia. Hydrolazine comes like 5 milligram IV or IM doses can be given, and the dose in gap should be between 20 to 40 minutes interval. But they always almost maternal hypotension in happening with higher doses are also noted. Nifedipine again can be given as oral route, and one must avoid the sublingual doses to avoid sublingual doses for severe hypertension.
Absolutely. So one of my experiences, I would like our panelists also to add on to it, is that when such kind of severe hypertension are there and you lose labetalol, the outcome in terms of lowering of blood pressure, I've always found it to be not so great. That is why I always have preferred nifedipine or a hydrolysine if the BP doesn't get controlled with that, with 1 or 2 doses of nifedipine doesn't control. Hydrolysine is a wonderful drug. Yes, hypotension can occur, but I think if you're doing it in an intensive care situation, we don't have to really worry too much about the use of hydrolysine. And hydrolysine is available freely now. There is no issue about that. Would any of the panelists would like to add any comment for this particular observation?
Yes, sir. I would like to say that few of our patients needed NTG drip for lowering BP. 5 milligram per ml drip was needed for lowering blood pressure.
NTG is one of my most favorite drugs, but I prefer to use it only in the post-delivery period. It acts wonderfully well. The only issue with the NTG is tachyphylaxis occurs, so you cannot extend your dose beyond 24 hours because of tachyphylaxis.
Yeah, I absolutely agree with Dr. Prakash, sir. We have an experience of using NTG drip, and especially in postpartum eclampsia when the BP is not controlled with labetalol. Days back, we were not getting hydrolysine. So at that time, that was the drug of choice to bring down the high blood pressure. And I always prefer a combination of, like how you said, labetalol intravenous with nifedipine. That is my choice always. That will work out much better than labetalol, that we have also experienced.
Thank you. So we
Sir,
move further.
one more thing I just wanted to add was, like the case that you just gave us the example of, a benign blood pressure of just 140/90 was ignored, and she came with such a deteriorating condition within just 2 days. I think maybe even in our practice, we should all make it a point that we keep such patients maybe in the labor and delivery, observe them for maybe just from morning till evening and see whether there is some accelerated response to and sudden rise of BP, so that we can catch them early, and treat them at the right time rather than treating them when the whole damage is done. So I think a benign blood pressure of 130/80 or 140/90 should really be an eye-opener for all of us.
Yes, very well. We know that HELP syndrome occurs not only at a higher blood pressure level, even a normotensive or slightly a borderline hypertensive can develop HELP. So that we have to observe. And again, for epigastric pain, I always prefer, you can give a shot of pantoprazole with antacids, but if she is not responding to 1 or 2 doses, it is always safer to have the patient under observation. And maybe if an pre-eclampsia investigations will help her at this situation, we have to observe. Then again, is there a role for ultrasound in patients like this? Because this edematous liver can be then gallbladder, and the stretching, this Glissant's capsule will be becoming more prominent in these patients. And we can find out some subtle type of ascites can also be picked up by ultrasound. So maybe at this stage, if you are going in for an ultrasound, it can show us some light towards the diagnosis.
So this patient was started on IV Maxself after a loading dose, of course, 1 gram per hour and platelet infusion. She had convulsions on magnesium sulfate, so 2 grams of rescue dose was given. Platelets and FFP transfusion was continued. Emergency LSC has done. A live BB of 900 grams shipped into an ICU, put on ventilator. Post-surgery, patient was ventilated on fentanyl, NTG, and blood products. Now, patient was settling. Actually, I left her and started attending on to my other work. She had a sudden episode of hypotension 6 hours after surgery. And post-hypertension, it was found that the pupils were dilated. The uterus was well contracted. Bleeding was within normal limits. The urine was clearing up in the tube. But this episode of hypertension and a dilatation of pupils was what was very worrying. Patient gradually lapsed into coma. The neuro opinion expected a possibility of intracranial bleed. A CT brain was done, and it was found that there was a subarachnoid hemorrhage with intraventricular extension. We gave totally 22 transfusions to this patient, but the patients continued to deteriorate, and we had to declare her dead in 24 hours after referral. The relatives elected to take away the baby, a 900-gram baby, which would have probably made it. They elected to take away the baby, so we landed up losing both the mother and the baby. As Madam Ramani pointed out, all because of a simple thing when epigastric pain was ignored. So let us be careful about our patients. Don't think pre-eclampsia is 180, 120. No, a blood pressure of 140 by 90 is equally dangerous. I'm sure all my panelists will agree.
Yes.
Yes, yes.
Yes, sir.
Okay, next question goes to Dr. Shaini. What are the other CNS complications that occur with preeclampsia? We saw one complication of hemorrhage. What are the other complications that could occur?
See, thank you, sir, for that case discussion, and which has taught us a lot. The other CNS complications that could occur are maybe stroke, then due to cerebral venous thrombosis. There could be very subtle intracranial hemorrhage that can be there, but may not present clinically as anything. So evaluation of the end organs, including an MRI, is very important in all patients of severe preeclampsia very early. And also sometimes blindness, like you have pointed out in your slide, can occur due to that severe occipital edema, and even sometimes due to retinal artery occlusion. That can become a permanent blindness, which you cannot reverse at all. No, if it is just an amaurosis due to occipital edema, that reverses probably within a week's time, or maybe even earlier. But if it is a retinal artery occlusion, that can be an irreversible blindness for the patient.
Absolutely. The more MRIs we are doing, the more presses is what we are identifying now.
Yes.
So we have to keep press in mind, and quite often the patient comes back to normal within 24 hours. You know, we are in a wonderful specialty. The previous evening, I would be talking to the patients that your patient may die, and we manage our patient well, and next day morning, the patient is sitting on the bed and asking for food. So that's the kind of specialty we are in. And but it also means that we get only 6 to 8 hours to manage these complications, and we should be very quick in our response.
Sir, one question. Do you want to have a plain MRI or a MR venogram? Because the radiologists in our city, they are always asking for MR venogram to detect the cortical venous thrombosis. So what is your choice?
Madam, unless it's a little bit of a delayed presentation, let us say she has come to me on day 4, day 6, day 8, I would definitely do an MRV also. There is no two doubts about it. Okay. But in this acute phase, a plain MRI is better. And you know, these kind of patients, MRI can never be given in the intensive care situation. They have to go down into the MRI room, and you know, you want to finish it quickly and get her back onto the bed. I've had patients who have thrown convulsions in the MRI room. I have patients who have had arrest in the MRI room, and we have to call a code blue in the MRI room. So those kind of things also happen. So we try to keep our investigations minimum in acute phase, but a little bit of chronic history is there. Definitely, yes. Okay, I think okay. Now we know that this patient was HELLP syndrome. So Dr. Swati, could you tell us what is the other differential diagnosis that you would consider?
Yes, sir. The other imitators rather of HELLP syndrome would be AFLP, that is acute fatty liver of pregnancy, the TTP and the HUS complex, which is thrombotic thrombocytopenic purpura, and the hemolytic uremia complex. Apart from that, there can be a lupus flare or even viral hepatitis, which can also be present. So it's very important to know how to differentiate between each of these.
True. What happens is that sometimes most of these conditions merge seamlessly into another. It's very, very difficult, in spite of whatever we say, to differentiate, let us say, an acute fatty liver of pregnancy from a HELLP syndrome, which is of severe variety. yes, we have the values. We say, okay, if liver enzymes are so much, it is possibly health. If liver enzymes are so much, it is possibly AFLT. But in practice, it is very, very difficult. And I specifically got a gallbladder in this because one of my earlier health syndromes, I'm talking about 20 years back, I called the GI surgeon to see the patient because I was worried why she has got epigastric pain and right hypochondriac tenderness, whether it is due to a gallbladder etiology. And he came and he saw and he says, all right, let us do a scan and then we'll decide what it is. By then, the patient threw a convulsion. So I told him, no, now I know the diagnosis. It's not your subject, it's my subject. And this was my first health syndrome. You never forget your first cases. So this was one of them. Okay, we go to the next case, a 25-year-old.
I just have a comment. I agree with Revati. I mean, some of the previous things I would just kind of don't want to drag out the discussion, but like about the uric acid, I mean, there's intentional that uric acid is not in any definitions of preeclampsia. I mean, I know people check it, but there have been several studies that uric acid independently does not contribute anything. So I know you guys are checking it just because you want to get close to your diagnosis. So it's not wrong, but I do not look at the uric acid. And you don't really use it for determining timing of delivery. It doesn't prognosticate anything. It's not really independently associated with anything. The question I had was two questions. The first case was a bit different than the second one. Do you guys use like full pairs or some sort of like a clinical parameter, or that's like not a thing that it's used in India?
No, that is what we are trying to teach people because unfortunately it so happens that the people who come into the conference are not the people practicing most outside.
Yeah.
That is what happens.
And
that is why by these kind of programs and by doing the PENAI program, we are hoping that, we reach out to that crowd.
Yeah, agree. Because sometimes, I mean, the second case, I don't know what would have been the outcome because she was obviously, in bad shape by the time she even got to you.
Hopefully.
And then I would just have a question. There's so many participants here. How many people have access to biomarkers? Because we just recently published a paper in AJOG that even with full pairs, and obviously our data did not have all the full pairs variables like oxygen saturation and all those things. We don't, I mean, by the time the patient is deoxygenating, you don't really need to, need any other test. But definitely biomarkers actually add, and I can send that paper over to, I'm somehow not able to attach that in the chat box, but I can send it. So we looked at full pairs model and independently broad definition of I-SHIP, restrictive definition of I-SHIP, and biomarkers add to prediction of adverse outcomes. So I don't know, I'm not propagating it, but there is so much literature, and you guys are like, if you're confused about diagnosis, or if you have a patient like that first lady had mild hypertension, some right epigastric pain, I bet if you measure her soluble FLIT and PLGF, it will be off the roof. So I think, there definitely, if it's approved in your country to be used, I would highly recommend to, I mean, I know Revati uses it, but like in Germany, everybody uses it. They just routinely use it. So you'll familiarize yourself and maybe reduce some of this confusion. I mean, that's the end result. That's what we want, is that perhaps that can help expedite people to transfer patients fast. So even if your condition is not really clear clinically, all these clinical parameters, and you guys are such excellent clinicians. I mean, they're just not really predictive. That's why women are dying from preeclampsia, because hypertension doesn't predict anything. Proteinuria doesn't predict anything. You can have help with normal blood pressures. You can have a seizure with normal blood pressures. So I would say that, if you have access to the biomarkers, you can perhaps use it to differentiate some of these cases. I mean, maybe you guys are all in the tertiary center, but definitely if you're not in a tertiary center and if you're confused about the diagnosis, especially preterm, you can definitely check those. There's very strong evidence that biomarkers provide additive value to your clinical assessment.
Absolutely, fully agree with it. But again, as I pointed out, that these are patients that are referred either from the periphery or from a small hospital in the city. Unfortunately, nothing, even if they are taken a proper history, that the first patient has got enough in the history to tell you that, yes, she's going to give you trouble this pregnancy. But it's unfortunate. That is exactly what I told you we are trying to change. We are hoping it will happen in a lifetime. So this next patient was a Gravida 4, Para 3, living 2, 1 dead. First pregnancy was an IUD at 8 months, cause was not known. She was referred due to severe pre-eclampsia, possible diagnosis of HELLP syndrome with DIC and FGR with previous 2 LSCS. There was a history of swelling of lower limbs since 1 week, raised blood pressure and epigastric pain since 3 days, and decreased fetal movement since 2 days. No history of headache, blurring of vision, bowel, bladder disturbances, fever, bleeding, leaking PV. In that nursing home, at least they have done a platelet count which was 54,000, urine albumin of 2 plus, creat was 2, and uric acid was 8.5. So when she was referred again, she came with as like a previous case with 20 ml of urine output, and there was a hematuria. Okay, when she was taken up for the surgery, by the time, in spite of giving platelet transfusion, you know, SDP is sometimes very difficult to get immediately. Like a single donor platelet is always better. You have to use pheresis platelets, but you know, even in an institution like mine, when I need an SDP, it's not available. So I landed up using RDPs, and she was given 8 RDPs pre-op, but still when I operated on her, platelet was 12,000. Abdomen was open, ascites was present, there was no LICA, 1.46 kg baby shifted to NICU, intraperitoneal and subcutaneous drain put in, bleeding PV was within normal limits. But the only thing that happened was that there was a blood-stained urine 30 ml at the end of surgery. 4 units of platelets and 1 FFP was transfused intraoperatively. Injection tranexamic acid, 1 ampule was also given. Patient withstood the procedure well. She was shifted to ICU. In the ICU, again 4 RDPs, 2 FFP, 1 SDP, 1 PRBC was given on post-operative day 1. Now this was a post-operative case, like Madam said. NTG is a wonderful drug, so we had started NTG on her. Antihypertensives were given as per BP. She had some low HP on day 2. So again, 3 units of Paxils was given. And this was the previous investigations, what I was telling you about. So this is how the baby was. Now we had to put a central line in her. There was bleeding from the central line. There was bleeding from the incision site. You can see the platelet, the ABG, that there was an acidosis, which later on got corrected. And then she went into renal failure because, as I told, very little bit of urine came out in the immediate post-operative period. Her creat started to go up. She had to be put on dialysis. Once we started dialysis, within 48 hours, the urine initially, which was blood stained, started coming out. And finally, we had a very clear urine coming out. So by the 4th post-delivery day, hemoglobin was 12.1 with a platelet of 72,000, and the LDH now had come down to 675. She needed repeated hemodialysis cycle up to 6. Then on day 17, the creatinine became 3.6, and the IJV catheter was removed. The mother and the baby were discharged in a stable condition on post-operative day 18. Blood transfusion, totally she received 24, including blood and blood products. Post-discharge, the creatinine that is on day 14 when she came, the creat was 1.5 and the BP was well controlled. So the next question goes to Swati. Is fluid balance important?
Yes, sir. Fluid balance is very important because mainly it prevents the hemodynamic compromise leading to acute kidney injury in such patients. So one should be very vigilant not to overload the fluids and which particular fluid to use, how much of crystalloids to give, and where to avoid colloids should always be considered. What we see mainly is when fluid overload is one of the most common cause of maternal death, mainly because of pulmonary edema. Also, one should be very vigilant that they should not overuse diuretics because these patients have very little of intravascular volume, which further gets reduced because of overuse of diuretics. Therefore, one should be very vigilant about the fluid balance.
Absolutely, the fluid input in this patient is very important. You give her too little fluid, it will result in renal injury. You give her too much fluid, you will get pulmonary edema. And most of the causes for the maternal death is iatrogenic fluid overload. The patient just goes into pulmonary edema just like that. And unless you're careful about it, you're going to lose her. And we need to remember that once delivery is accomplished, spontaneous diuresis begins within 24 hours, and the disappearance of the excessive extravascular fluid takes about 3 to 4 days. But what is more important is that most of the problems of fluid overload begins around 16 hours after delivery. What happens is most of us are careful the first half an hour. Some are more diligent, they're careful for the first 24 hours, or rather first 2 hours, and the remaining quite often careful for the 4 hours. After 4 hours, you tend to forget about the patient. And as obstetrician, the biggest worry for us is postpartum hemorrhage. You say, okay, there is no PPH, uterus well contracted. Okay, fine, nothing to worry. But the problem comes in 12 to 16 hours after delivery. So that's the importance of monitoring the patient even after delivery. The next question goes to Dr. Shaini. Next, the commonest complication.
Dr. Mehta, can I ask a question?
Yes, please.
When you have your postpartum patients, where do they go? Do they stay on labor and delivery, or they go to like different floors?
No. Postpartum, if they are pre-eclamptic patients, they go into high
This
dependency
lady, where will she go? Will she
high
be on a
dependency unit? Most of them go into high dependency unit. In places where there is no high dependency unit, quite often for 2 hours only, they are kept in the labor room. That's the mistake that's occurring, because everybody loses the interest in the patient once 4 hours are over.
Yeah. You know, we have the same problem here, maybe not to the same extent, because we sometimes don't see such sick patients, but we don't typically send these patients sometimes if there's a problem with urine output, especially definitely she was going into renal failure, off to our postpartum floor, because just the frequency and the nursing, I don't know how you guys determine your nursing ratio. Our nursing ratio on a regular postpartum floor is like 1 nurse to 5 patients or 6 patients. And then we have 1-to-1 nursing when the patient is on labor and delivery. So we actually sometimes keep these postpartum patients, especially when, there's a concern for bleeding, concern for help, concern for she has massive thrombocytopenia. So obviously there's concern for bleeding and renal dysfunction, like on labor and delivery, just for this, so that people can take, hourly vitals, hourly urine output, and people can check their labs. So I think maybe just like even considering where you are putting your patient so that you can give her the right resources, maybe just a practical way of just by default, if she's on labor and delivery or some of your higher units, she will get those hourly vitals. She will get those labs that somebody's going to look at and kind of take care of her quickly. But I agree, the postpartum period is just like actually sometimes even more dangerous for some of these patients. Yeah.
I also wanted to add,
the government of India, we are trying to get HDU introduced in many of the hospitals. It has happened in quite a few hospitals. Quite a few medical colleges now have got a high dependency unit. The first time I remember when I had a meeting with the government officials and we talked about high dependency unit, they said, wow, we are not even able to manage anemia. What are you talking about high dependency unit? But I should say that now high dependency unit is becoming an absolute reality in most of the places.
Yes, I just wanted to add that for acute kidney injury, few of our patients were also managed with the plasmapheresis.
Yes.
Cycles of plasmapheresis.
Yeah.
And
we use it quite often. Plasmapheresis we use quite often. The only worry is because I'm in a private sector, the cost is much more than as compared to a dialysis.
Okay.
So, but if you are suspecting CTP, possibly the plasmapheresis would be one of the best treatments. Okay, Dr. Shaini, the question to you.
Yes, sir. Thank you. Yeah, thanks for that question, sir, and I think you put it in a very good way of preventing and managing. So prevention comes right from the patient who's a non-severe or a severe PE walks into our labor and delivery unit, because the moment you see a non-severe patient, she's just like a time bomb. You never know when she's going to go into a severe phase or when she's going to become an eclamptic. So in these patients, you need to restrict fluids and balance it with the urine output. So the most important thing is if you have a high risk labor room or a high dependency unit, keep these patients there so they get extra care with both a nurse as well as a doctor. And monitor their strict urine output, and whenever you see that the urine output is decreasing, make sure that you repeat investigations at least 6 to 8 hourly in these patients, so that we can manage fluid intake for them. And also, if the patient has already gone into pulmonary edema, the earliest sign to pick this up is maybe oxygen saturation dipping or patient becoming breathless. It may not be frank signs of a frothy secretions or anything, but subtle signs like breathlessness, patient having air hunger, or sitting up and saying she can't breathe, and just seeing the oxygen saturation itself can tell us that probably this patient is going into pulmonary edema. And of course, when it comes to management, although diuretics are contraindicated in these patients, we have to shift them to an intensive care unit, and they will require positive pressure ventilation and also probably a Lasix infusion.
Sure.
Without that, it's a life-saving thing for such patients. Although we say we should not give Lasix in these patients, but Lasix infusion in case of pulmonary edema is one of the life-saving drugs.
I think you brought out a very important point. Please remember that if you're giving Lasix, do not give homeopathic doses. 10 milligram or 20 milligram is not even going to do anything. Yes. I've had to give anywhere between 60 to 100 milligrams of Lasix to these patients before the pulmonary edema settles down. So don't give a small dose. Don't do that at all. The second important point is that we should never forget that in the patient with pre-eclampsia, in the post-delivery period, there is a mobilization of the interstitial fluid into the intravascular volume. And the second important thing is the endothelial damage also occurs in the pulmonary capillary bed. Correct. So these two together, even if you have not given, because I have seen patients where I have been very strict with the input of the IV fluids. I've been standing with the patient for more than 1 hour at that particular time, and the patient still went into pulmonary edema. Possibly, if I was not standing there, I would have blamed my resident and told them that you have given off too much fluids. But since I was standing there, I was very sure that no extra fluid was given, and still it happened. So remember that it need not be your mistake all the time, but you have to be careful with this patient because of the endothelial damage, and of course renal dysfunction adds on to it. We also need to remember that if the patient is in positive balance of over 2 liters or low oxygen saturation starts occurring, like Madam Shaini said, immediately give her a Lasix at least 40 milligrams. Don't start with 10 milligrams. And also remember that it is far safer and sensible to run a patient dry and restrict IV fluids. If there is a little bit of kidney damage occurring, let us say for argument's sake, you can still manage it. But a pulmonary edema becomes absolutely life-threatening, and whether we like it or not, in most of our labor rooms, are not equipped to manage a pulmonary edema patient. But most of the places you can't even intubate a patient when such a thing is happening. So let us be careful. Let us keep the patient a little bit dry. And of course, now at least in most of the bigger places, you have an ultrasound machine available. Just do an IVC diameter. If you see a collapsed IVC, the inferior vena cava, if it is collapsed, give her more fluids. If the inferior vena cava is full, cut down on your fluids. That will help you. And whenever these patients are put on a ventilator, remember a high PEEP is required, because when you give a high PEEP to them, the fluid from the alveolar sacs gets pushed back into the intravascular compartment. So make sure you give a high PEEP, and then these patients would do well. Next question to Dr. Swati. What are the hepatic complications that you could have?
Mainly the patients with hepatic complications usually have vague symptoms like general malaise, nausea, vomiting, and obviously epigastric pain, that is the right upper quadrant pain. And moreover, they do have raised transaminases, that is the ALT, AST would be very much elevated. This is mainly because of the hepatic cell necrosis. And also there were very rare case reports of liver rupture leading to hypovolemic shock in patients. And moreover, one has to be very important, remember that whenever there is liver parameters derangement, it is almost a marker for a DIC. So these are
most
the
of the
complications.
complications, including renal failure, will be seen more frequently if you have a DIC associated with the condition.
Yes,
as far as liver hematoma is considered, let me tell you, it's one of the most scariest condition you could have. I see all kinds of problem patients, but liver hematoma is something that even now makes me shiver in my pants. Because when they rupture, in spite of how much ever big we talk, we don't have enough time to save them. That is what happens. And in my very, very early days, again, I would just like to tell this so that you become aware of it. This was an 18-year-old girl who came with thrombocytopenia at around 16 weeks of pregnancy. And we found a liver hematoma. At 16 weeks, I'm talking about, again, another 20 years back, we would never think of a pre-eclampsia at 16 weeks. Today, I say, whatever the period of gestation, first I'm going to rule out pre-eclampsia. And she ruptured her liver in the ward. And before we could shift her to OT, she expired. So if you see a liver hematoma, or especially if you see a DIC in your patient, you find low fibrinogen levels, or you find that the platelets are very low, 10,000, 20,000, in spite of your transfusion, please be very, very careful with these patients. So this is just to summarize all the complications, starting from HELLP syndrome, abruptio placenta, DIC, acute renal failure or acute kidney injuries, pulmonary edema, neurological problems, maternal death and perinatal mortality can all occur in the patient with pre-eclampsia. And these are the figures in my series. You find that the HELLP syndrome and the DIC and the perinatal mortality is much more commoner in my series, possibly because I look at a skewed population which are referred in a rather late stage. The next question to Dr. Jyoti. I know we have discussed part of this. Dr. Hemavati discussed it beautifully before, but we would still like to repeat it so that we all get tuned to the postpartum management. So Dr. Jyoti, in severe pre-eclampsia, what is the ideal postpartum management?
Yeah, the follow-up of this patient in the terms of blood parameters should continue even postpartum till it normalizes. Second, control of blood pressure is very important. Here we can use drugs like amlodipine, ethanol, even ARBs can be used if the blood pressure is not getting controlled. And definitely Maxel for 24 hours after delivery or last conversion, whichever is later, is to be done. And postpartum thromboprophylaxis.
Yes, thank you for bringing that out. In spite of whatever we say, in spite of how much ever it is talked about, NSAIDs are used in severe pre-eclampsia patients. Please remember that kidneys are already precarious. And if you give an NSAID, you will push her into an acute kidney injury. I've had at least 4 patients who have come in like that. So don't use NSAIDs in this patient. Patient complains of pain. You're also tired. You're given one paracetamol, and then you feel no, she's still not got enough pain relief, and you go and give one INAC or some such drug. So please tend to avoid it. The second important point which Dr. Jyoti brought out well is that thromboprophylaxis is important in this patient. Yes, we know we are talking of low platelets, we are talking of DIC, and it would be a little worrying for you to use heparin in the post-delivery period because you're worried that the PPH may restart or whatever. But these patients get a rebound thrombosis in the post-delivery period because the pregnancy changes are going away. So please use thromboprophylaxis. The other thing which I've observed, and that's why I put this point in, is that even in the post-delivery period, proteinuria sometimes is done even 4 times in a day to check for the urine proteins. So proteinuria persists for a long time after delivery. If those who have seen, you will see that sometimes it persists even for 2 weeks, and it is of no consequence. So let us not waste money on efforts on a test which is not going to give us any clue whatsoever. And next question,
Madam, before you finish that, I would add Lasix to your list of things for the postpartum period. So there's a good randomized control trial, not obviously in your patients who have renal dysfunction. Lasix is not indicated in those people, but in your garden variety preeclampsia or severe even gestational hypertension, we are even giving it to chronic hypertensives. Lasix acutely between day 2 and day 5, there's like a large RCT which was published in Hypertension, which showed it reduces the trajectory of blood pressures and reduces blood pressures like post-discharge. So I would highly recommend, I can send that paper again to Revati. It was published a couple of years ago in Hypertension. There's a large randomized control trial done here with Lasix and no Lasix, and they found that using Lasix, just 20 milligrams PO once a day for 5 days, day 2. So it's like after your day 1, you're done with your hemorrhage, you make sure that the patient is like actually making urine and MAG is over. Yeah, I will send that paper to you, Revati, and you can share that too. I send you that other paper too.
Sure.
But yeah, I would highly recommend. All those things are perfect. I'm not so much sold on thromboprophylaxis in patients unless they're obese or have a C-section. But I mean, if it works for you guys, that's fine. I agree. I mean, they do have a risk for thrombosis all the way up to 6 weeks out. So definitely, I think, just maybe consider Lasix and, just start giving it and see if you see a difference in their blood pressures and see if you guys, that would be something that can help with the blood pressures too.
Yeah, sure. One important message we need to remember is, Madam Sarosh Rana brought out very clearly that you don't use it on day 1. It's only after day 2.
Day 1, because you want to make sure that the urine output is established and she's obviously not going into renal failure. Her hemorrhage is controlled. So even in the RCT, they actually used it after day 1. So it was after your first 24 hours, then you give them Lasix. And obviously in the trial, they didn't really check everybody's creatinine, but in real practice here at the University of Chicago, I always grab a CMP after delivery just to make sure her creatinine is normal before I start giving her Lasix. So you can do that too. And it seems like you guys are checking labs postpartum quite frequently anyways. And just one question about the labs, at least in clinical practice here, if we have patients who have non-severe disease, we check their labs, even if the labs are normal, once a day while they're in labor, and then one time postpartum. If they have severe pre-E and they even by blood pressure, they have normal labs, we're checking them Q12 hours. But if they have any lab abnormality, we are also checking them every 6 hours during labor and acutely postpartum. So yeah, checking frequent labs will actually give you, where is your platelet count doing? Do you need to do a quick C-section or, obviously liver hematomas and all. I haven't seen much, but you got to get them out of danger before that happens.
Absolutely, because most of the complications of preeclampsia are dependent on your lab results. So you should never miss out on doing enough labs for these patients. And the first 24 hours are very important because the fluid shift from interstitial to intravascular compartment is occurring. Once that is over, you use Lasix. Great. That is why the recommendation is after.
Actually, yeah, recommendation. And they also found that the amount of antihypertensive use was also less.
Great.
So if you use so you can sometimes just only get by using Lasix and you don't even have to give her antihypertensive. But even if you have to give her antihypertensive, perhaps the doses that you have to use will be lower. And it's very acute. It's only day 2 to day 5. So it's not like you have to, day 2 to day 7, it's like 5 days of Lasix. It's not that you're going to give it to her for weeks and weeks.
Absolutely. I think anybody listening over here could start it as a research project in their place and see really how much it helps. Okay, next question to Dr. Ramani. Are there any long-term effects, long-term complications of preeclampsia?
Definitely, sir. There are quite a few of the long-term complications. Like how we say that gestational diabetes is a forerunner for a early onset diabetes in that particular patient. We can predict that preeclampsia is also going to be a forerunner for a long-term diseases. For example, the patient is likely to become a permanent hypertensive. And then because of hypertension, she is at a high risk of developing ischemic heart disease and then stroke and cardiac failure. And then she is also at a high risk of developing coronary artery disease, metabolic syndrome, diabetes. I always view that hypertension and diabetes are like twin sisters. If one is going to be present, soon the other will join the first one. And entirely, it is basically based upon the endothelial dysfunction the patient has got during the pre-eclamptic phase, and all the pro-inflammatory factors are against this patient. So actually, this patient is at a high risk of developing cardiovascular morbidity and early onset coronary disease and metabolic syndrome, and so many, like chronic renal disease can also happen. and premature death is known to occur when you compare these people with a patient who has got no preeclampsia. So it is a warning sign for all the women, that as well as for the consultants, that we must tell them that you are at a high risk of developing cardiovascular morbidity at an earlier stage, and you have to undergo lifestyle modification and monitoring. Definitely till the BP is controlled, we have to monitor, and then every year the patient should undergo all the basic profiles, and including lipid profile, electrolytes, and then one ECG and echocardiogram. This echocardiography, we can pick up whether the patient has got a preeclampsia or it is a secondary to chronic hypertension. So that is by the simple way of measuring the left ventricular muscle mass index, we can differentiate, and this will be a warning sign. So we can also do a HSCRP, which will give us an idea about the inflammatory status of that particular patient, and warn them that they are at a high risk, and put them on, if the hypertension is not controlled, we can start them on some ACE inhibitors or beta blockers as per the consultation with the cardiologist. So this is my way of approaching a pre-eclamptic woman, and the most essential thing is she has to have a lifestyle modification, control diabetes, control obesity, and periodic monitoring. That's the only thing. Exercise, diet.
Thank you, madam, for bringing that out. We are now coming to the end of the panel. I hope all those who are listening to us would have taken at least 4 to 5 clear-cut messages. Number 1, remember about Paxil volume. Number 2, remember about LDH. Number 3, remember about the postpartum acute management of your patient. Number 4, don't forget that your patient has to worry lifelong. And number 5, you add on to that the effect on the fetus in its future life, and make sure that that fetus is also followed up very well. We are the basic physicians for the women, and it is our duty. Please don't depend on your physician or your family doctor to tell the patient all these things. It is our duty to tell them when they come for the 6 weeks visit back to you, sit with them and talk a lot about their future life and what issues could come up in future life and how they could prevent it. So to conclude, both maternal and fetal risks can be at life because of pre-eclampsia. Multiple issues are involved. A good balancing act is required. Quite often we need a multidisciplinary approach. Early transfer, please do not hold on to the patient. I know nobody likes to lose the patient, but once the patient gets bad and after that you refer, the outcome is very poor. So you have facility, please go ahead. You may be very intelligent, you may be very achieving kind of a person, but if your center doesn't have that kind of a facility to manage the patient, let the patient be transferred to a better center. Don't hold on to the patient. And more important, community education is very, very important. I've had patients coming and telling me that the next door auntie told them that a little bit of blood pressure during pregnancy is absolutely normal. Doctors asking you for admission, but don't get admitted. It doesn't matter at all. Things like that. So we have to do a community education. And that is why during the iShip 2023 Congress, we are planning to open up a patient advocacy program for all over India. We are hoping to have the PENAI Foundation people also coming into the program, and we'll be starting PENAI advocacy program for the patients. We are going to have special patient programs on that day. Please join us in this matter and make sure that you also talk to your patients, and we all together only can build a community awareness in this particular disease. And of course, the stellar role of biomarkers has already been emphasized. When you have nothing else, we know that blood pressure may or may not be normal. We know that albumin may or may not be present. We know that some of our blood tests can change suddenly over a period of 6 or 12 hours. Then the only thing we can fall back is on the role of biomarkers. Yes, it is expensive now. Yes, it is time consuming now. But if more people use, possibly the cost will come down. Possibly the availability and the results coming in would be much faster. So let us use them. And I thank my panelists for a very wonderful panel. I kept them in totally dark about the patients that I'm presenting, totally dark about what questions I'm asking. And you saw that with their experience, they answered and conveyed the messages wonderfully well. Thank you all the panelists, and thank you for the patient hearing, and hope we have sent some clear-cut messages. Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you so much, sir. As always, it
Thank you.
was a great time to listen to the panel, so elaborate and so educative. Next on, I would like to invite Dr. Revati. She would be giving us a small snippet into the making of PENAI program, which we have been listening to a lot, about the ISHP and about the special inauguration of the day. I would request all our delegates to stay back and be with us for the inauguration of our new program after Dr. Revati's talk. Thank you. Dr. Revati?
Yeah. Now, while she's pulling up, I just also sent, there was a recent review article that we wrote about long-term cardiovascular disease, and we put some like figures in there as to how frequently you should see these patients, in the early postpartum period, and then every, in 3 months, in 1 year, and what do you do at 3 months, what do you do at 1 year? So I just sent that to Revati as well. Perhaps you can look at that as well and see if you can incorporate some of those things in your practice. Yeah, so they need a very regimented postpartum follow-up for like rest of their life. And you should have those programs in your clinics to either hand them off to a cardiologist or to a primary care doctor, if obviously you guys are not doing care beyond 6 weeks.
Dr. Revati, I think your video is not.
Yes. Thank you so much, Anu, and thank you so much, Dr. Sarosh. I will send all the articles to the delegates as well. It will be very helpful. And the whole idea of doing the VLSPE series was to take PENAI across to the length and breadth of the country. And the best part of it is after the program has been held, we've had a lot of people opt for the PENAI course, which is very, very reassuring. So basically, we've had a discussion, we've had a capsule, we've had a panel for all those delegates who are yet to register for the PENAI. So moving on, let me tell you what this structured program is all about. So it is called the Pre-eclampsia Education of the Nation India program. So it's basically a certification course for practicing obstetricians and established consultants, postgraduates, residents, which gives you all comprehensive information, including the guidelines on pre-eclampsia management. It's a joint collaborative venture of the Society for Maternal Fetal Medicine India, along with the International Society of Study of Hypertension in Pregnancy. There's some problem. The slide is not moving. Chitrakala, can you please, sorry, Sahiti Priya.
Please click on the slide, ma'am.
Yeah, okay. It's not moving. Can you share the next? I'll do one thing. I'll stop share. There must have been an internet issue right now. Can you just help, or should I re-share the slide again?
Yes, ma'am.
Or I think Sahiti Priya, please help me share it. Hello?
Yes, ma'am.
Can you share it for me, please?
Yes, ma'am. Yes.
Yeah,
I'm
I got
sharing.
it. It's fine. Are you sharing it?
Yes, ma'am. I'm sharing.
Okay. Just let me know when you have finished sharing it. Hello?
Yeah, move to the next one, please.
Basically, the Indian co-chairs are Dr. Prakash Mehta as well as myself, and the global co-chair is Dr. Sarosh Rana. And basically, why we wanted to do this program is basically, we know that it is preeclampsia is one of the leading causes of maternal morbidity and mortality in the country. Atypical presentations are very common. There are implementation issues. There are challenges existing in extrapolating the global research. So we are discussing a lot about global research program, but can we implement it into our practice even at the grassroots level? So there was a felt need, and that's the reason we did it. We started off with the SMFMI office. We collaborated with Medinet. We had Roche, who also gave us the support to start the pilot project. It was kind of funded for the pilot to set up the pilot. And there was a lot of emails, there was a lot of networking. We had to get all the faculty from the entire country who were actually doing a lot of work on pre-eclampsia. We also got the global faculty to participate. And this ultimately, are you seeing the slides? Are you seeing the slides? Are you seeing the slides?
Yeah, we can see your slides.
Yeah.
Yes.
So, yes. Okay. And basically, we had to design modules based on collaborative efforts, making it very clinicians friendly, adding the definitions, classifications, management dilemmas. And we got some of the best faculty, like we had Dr. Sanjay Gupte, we had Dr. Girija Wagh, we had our President, Dr. Prakash Mehta, do the panel. I presented the biomarker study. Dr. Sarosh Rana was talking about the angiogenic biomarkers. We had Dr. Laura Maggie present on the PIRES. We had Dr. Leona Poon talking about the first trimester screening. So we had the best faculty in the world talking about the management of hypertension. Can you see my slide? Hello?
Yeah, could you move it, please? Move to the next slide.
Yes, so we presented this at the iShip World Congress at the Montpellier, France, and whatever preliminary work that we did. And yes, there were some challenges because we could recruit delegates into the program, but many of them did not complete the course. So
Revati, you need to talk a little loudly, please. A little loudly.
Yes. And so we had to motivate a lot of these delegates by making repeated calls and sending email alerts to motivate them to complete this course. So moving ahead, we got this excellent idea of evolving into the on-site program, which we are going to inaugurate today. So this is basically a one-day certification course on pre-eclampsia. The conventional version actually was a 6-week program, but this is going to be a one-day certification course. We are going to the campuses, we are going to the medical colleges, we are visiting the societies to help us get the delegates. It's a joint collaboration again between the SMFMI and the iShip. We're going to have all the recorded videos being played. The assessment is going to be based, the certification is going to be based on assessment. So the delegates are going to participate in this program live and finish the assessments online within a week of completion of the course. And the best part is there's going to be group learning at nominal registration fees, which can be customized depending on the number of delegates. And there is going to be an opportunity to interact with world-class faculty during the virtual interactive session, followed by the final certification, which is going to have online. So you're going to have an on-site program where the learning happens, an online assessment, and an online virtual interactive session. In fact, we had one of the virtual interactive sessions today where about 21 delegates graduated. So basically what we want to tell you is this on-site program also, we also are going to inaugurate the webinar version where we're going to probably host these modules. There's going to be 12 hours of learning, which is going to be played like a webinar every week, and is going to be hosted by one of the SMFMI core members who have worked for PENAI. So this will instill a sense of group learning and interaction, because a lot of consultants have told us that it is difficult for them to complete the course unless and until they are in a group, so that they could probably feel that they are in a classroom and they are interacting. So this is to hasten completion time, because we are finding that people who have enrolled for the course are not really completing it on time. So this is also going to be open very soon. So we're going to intimate you. So we're going to have 4 sessions once in a week for a month, where you finish the learning, take the assessment online, and then be a part of the virtual interactive session, give the feedback, and finish the final certification. And just like what Dr. Sarosh said, all of these delegates will also, we are probably going to give them an updated module, which will have the most recent updated guidelines, which will be circulated to all as well, maybe for in a brief period of time. And the best part of the whole thing is all of you who are PENAI registrants will get an honorary membership of the SMFMI, which will last till the December 31st of 2023. So using this, you can also register for the upcoming iShip World Congress at discounted rates and be a part of all the academic programs of the SMFMI without any cost, which is really, really, I think, which is a big value add to all the PENAI recruits. Now, future of the course, I'm going to read this slide because we have really done what we thought we should be doing. At least we are in the course of doing it. We wanted to navigate beyond the pilot to reach out to all the practicing clinicians. So we have delegates from Bangladesh. They are about to finish the course. We're going to get them into the convocation soon. Periodic module updates, which is in the pipeline. We're going to have an updated module. Empowering clinicians with the latest evidence-based guidelines and research on PE, who can contribute to reduction in maternal and perinatal morbidity and mortality due to the disease. SMFMI is hosting the iShip World Congress. So iShip becomes a continuum of pre-eclampsia education, and we're going to get the best faculty in the world talking about pre-eclampsia. Extrapolation to the grassroots level clinicians and support staff like nurses with a similar learning module that emphasizes on diagnosis, stabilization, and referral protocols. So we are going to have mini PENAI workshops to fulfill all these objectives, which is planned at the iShip World Congress. Reaching out to global organizations for extended support, example, the Preeclampsia Foundation, which has been initiated to support preeclampsia research in the future, which will enhance quality of care in the country. The proceeds of the iShip World Congress have been planned to be invested for preeclampsia research and MFM educational scholarships and social service for pregnant women through the SMFMI. So these are our YouTube archives, which we will send it to all the attendees. You can be a part of all the programs. You can witness it at the comfort of your clinics. And then before I wind up, I'm also want to announce Pragna, which is the iShip World Congress 2023, which is going to be held in Bengaluru at the Indian Institute of Science and Sheraton Grand. Please register. The early bird registrations are open. We are also open for discounted registration for medical colleges. If they are going to register through group, please contact the office and we will help you through registrations. The abstract submissions are also open. We are looking forward for all the students, the registrars, as well as the consultants to showcase your work at the World Congress. Thank you so much. I hope you were able to see all my slides.
Yes, Dr.
Priya? Yes.
Yes, Dr.
Okay. So moving ahead, I think we will have the formal inauguration of the PENAI on-site and the webinar series, which is the new inclusion to the pre-eclampsia education of the nation India program. We are very glad we've had about more than 100 delegates registered to the course and about 35 graduate. And they have all graduated with exemplary marks. All of them have scored about 75%. Which is a tough thing in spite of their clinical schedules. Thank you so much. Sahiti Priya, please go ahead with the inauguration. Slides. Can you please play the inauguration slides, please? Yeah.
Shall I play the audio?
Yes, yes.
Pranamamyekam Shri Gauri Sutam Pranamamyekam Shri Gauri Sutam Pranamamyekam Shri Gauri Sutam Pranamamyekam Shri Gauri Sutam Anita Pavasudeva Bhakti Pranamamyekam Shri Gauri Sutam Anitalpavasudeva Bhaktam Dadadam Pranamamyekam Shri Gauri Sutam.
With the blessings of Lord Ganesha, we request the co-chairs, Dr. Prakash Mehta and Dr. Sarosh Rana, to inaugurate the PENAI on-site and the webinar series. Sahiti Priya, can you please? Yes. Sir and Dr. Sarosh Rana, can you please press the button? Or we will do it for you and we request you to inaugurate, cut the ribbon for us. Yes, Sahiti Priya, go ahead. Thank you so much. Dr. Anu, I think we have delegates who have just graduated through the course who want to give their feedbacks quickly, and then we have the closing remarks.
Before that, Revati, I think Dr. Sushma would like to say something, or you're keeping it later?
Yes, sir. During the closing remarks, some of the delegates want to leave, sir.
First, give the feedback, then we'll have Dr.
Yes,
Sushma.
sir. Yes, sir.
Yeah, because Dr.
Trishula
Sushma and Dr. Hema have worked wonders. They were our first chapter, and now they have arranged the first on-site session of the PENAI. We are very thankful to you, and we hope the best part about it is we started with 30. We thought 30 should be the maximum we should be taking, but I think they've already crossed 50. I don't know how many more they're going to take, but it is a very good and an auspicious beginning. We hope to do this across all over the country.
Do we have Dr. Trishula here? Can you unmute yourself and please give us your feedback, madam? Yes, I think Dr. Trishula is a senior consultant at Chinmaya Mission Hospital who recently graduated through the program. So can you please share your thoughts and inspire?
Yeah, it was a very informative lecture for me, and I always appreciate your concern about it, and I want to stimulate our junior colleagues to undergo this. I want to tell all my DNP students to register for this. That's what I want. Are you able to hear me, madam?
Yes, yes, Dr. Trishula, yes, go ahead.
I want to instigate all my junior colleagues to do this.
Thank you so much. Thank you so much. She's a very senior consultant who did the course so meticulously, and now she wants to encourage her students to take up the course, which is a very happy feeling. So next we have Dr. Jatinder Kaur. Do we have Dr. Jatinder Kaur? Can you please unmute yourself? Yes. And please introduce yourself before you tell us the feedback.
Hello, good morning, everybody. I'm Dr. Jatinder Kaur. I am a senior associate consultant working at Preeclampsia Dhirubhai Ambani Hospital, Mumbai. And it was just a wonderful PENAI course with good learning experience. I'm sure other delegates also feel the same. And it was good learning from our esteemed faculty, Dr. Prakash Mehta sir, Dr. Sarosh Rana, and Dr. Revati ma'am. I would say it's the need of an hour to learn more about pre-eclampsia, their complication, and the new biomarker, which are the new kid on the block. So, and it was really nice to have a panel discussion at the end, which was just excellent. It was like an icing on the cake, where all the possible cases were discussed. And I must say it was very well organized and executive program. So I will recommend all my juniors and fellow colleagues also to undergo this program. So my thanks extend to the whole team for taking out all the efforts and putting across this course very meticulously. And I wish all the best for the future events. And just a suggestion that if we can keep this WhatsApp group active so that we can get all the informations of the future events. And if we have any, suppose we have any doubt or any case to be discussed, which can be put across and our esteemed faculty can give the answers. So thank you very much.
Dr. Jatinder. This you will be put into the PENAI recruit group immediately. Now that you have finished the interactive session, you will automatically be included in the bigger recruit group where we are constantly in touch giving all the information. So you don't really have to worry at all. Thank you so much.
Thank you so much. Thank you so much.
Now, Dr. Anu, can we call Dr. Sushma and Dr. Hemapriya, who've taken the lead to set up the first on-site program after a lot of brainstorming to be held in Mysuru. They are part of the SMFMI Mysuru chapter, which also shaped up during the VLSP series. Dr. Anu, can you just call Dr. Sushma?
Dr. Sushma and Dr. Hemapriya. Yes, hi. Hi, Dr. Sushma.
Very good morning, everyone. Indeed, it's a honor and pleasure that I'm associated with Prakash Mehta sir. And I've been associated with SURF with many other programs which we organized in our institute. And it is really extremely overwhelmingly appreciated by the people of Mysuru. And it is a extreme pleasure that Mysuru is the first chapter of SMFMI which happened, and it is being accepted and appreciated by all Mysuru people and also the other districts. And actually, we have a lot of participants, not from Mysuru as well. We have participants from the nearby institutes as well, from Mandya, from Coorg and Chamarajanagar, and of course, Mysuru being the big district, and we are catering nearly 5 to 6 institutes. And when we announced the PENAI program, the registration was literally immediately accepted within 2 days. We had 20-30 registrations coming, and it was overwhelming acceptance. And currently we are hoping to have a great academic feast, and it's a great pleasure that we are conducting it as the first on-site program, and we really look forward to the great program. Yes, sir.
Do we have Dr. Hema Priya? Dr. Hema, you want to say something? Thank you so much, Dr. Sushma. We've actually devised this method to maybe like fast forward the learning so that they can learn it within a day and take the assessment within a week. So we have more graduates. So I'm just hoping, Dr. Sushma, it's going to work.
Yes, actually we're getting calls every day. We're getting calls every day. They want, especially all the consultants and even the postgraduates, they're very much interested. So right now I'm just limiting the registrations. I don't know, we may need to have one more on-site program very soon or something like that.
Actually, we are limiting our registrations only to the final year students. So because many junior students like second years, we told, because let us look at the registrations thing and then we'll include as the part. So we have currently limited only to the final year students, and literally they've backed the opportunity. And of course, the senior consultants as well are very much interested. And because all the protocols, whatever we have been practicing is fairly sound, and definitely this program will add on to the huge knowledge and make it our practice more systematic, and especially the newer advances and the markers. And it's really going to be a great help in our practice in preventing the complications. And after being listening to sir's many of his lectures, actually I have started implementing and using these markers in my clinical practice as well, and it's been a great practice, and I think we should be accepting and putting it in a larger spectrum, so that we're going to conquer this pre-eclampsia complications, and great work on we make our women more helpful for our people.
Thank you so much, Dr. Sushma. Many more to come. I hope all are going to come into the iShip World Congress as well.
Yes.
So we move on to the closing remarks with the co-chairs, and then Dr. Anu will take over for the vote of thanks. Co-chairs to give the closing remarks, please. I mean, the chairpersons to give the closing remarks.
Dr. Sarosh first. I'll end the thing.
Oh, well, I'll say the same thing as we said before. I think this is great. I'm so happy that people are learning and practicing, like I said, you guys are great clinicians, but sometimes just like relearning and do this in a continuous fashion will help our patients. And in the end, I agree. I think the patients depend on us to have the best knowledge, to have the latest kind of, at least in your head, so you can translate that into better patient care. I mean, they have nowhere else to go. That's what we do, right? They depend on us as clinicians to do the best clinical judgment so that we can literally save their lives. So I think it's great that this course is there, and I'm so happy that actually so many people like it. And that was one of the concerns early on, is because, to translate some things from like here, what we're talking versus what's actually going on grassroots levels is hard sometimes, because, we can write articles and then by the time it gets down, like nobody's following what you're saying. So I think it's really great that there are things that people can take and institute in your clinical practice and say, okay, if you do it this way, whether it's better or not, And I agree. I mean, I think biomarkers, if it's available to you, there's so much data right now. It's almost foolish not to actually, concede to it and say, yes, we have yet another test that can help us a little bit better, maybe find it faster, maybe predict preeclampsia better, rule out people better, and then provide a little bit of more sophisticated care. So this is great that you guys are learning, and I'm very happy that I was part of this. And then hopefully, I think this online learning was good, but I think this on-site thing is really fantastic, because I do agree 6 weeks is a long time to keep learning. If you can just pack it up in one day and have them just do all it together as a group is even a more fantastic idea. So that's very, very good.
Yeah, thank you everybody for being on our program. Now I should say I have got two very strong pillars with me in Bengaluru. The first, of course, is Revati, because it is with her, when she was my student, we have started talking about this program, and now everything has become an absolutely fruitful. And she's a never tiring, working, ready to work all the time. I'm a bad taskmaster. Anybody who has gone through a post-graduation or fellowship meet will agree that I'm a terrible taskmaster. But she does everything on time and wonderfully well. So thank you, Revati, for being there all the time. The next person, of course, is Dr. Anu Joseph, who has done all our virtual learning series. The first time I told her, she was a little hesitant. Should I do, should somebody else do? I said, no, you're the right person to do it. And we see now we have already reached the 5th program. And I'm sure Anu will continue the series in the near foreseeable future, because most of the people who have been supporting us, especially this complete VLS program, has been supported by Shield. They have been extremely good to us. Their staff is always available for help whenever it is required. And I'm sure this relationship is going to continue, and Anu is also going to continue as a coordinator. The next two important finds that we had was in Mysuru. Again, two youngsters, Dr. Sushma and Dr. Hema. We started with the chapter. We were not sure how it would run, whether they would be able to do it in Mysore, how will it go? And we found that they took it off. And the moment Mysore took it off, we got a slew of other offers to start the chapters. And as if that much was not enough, we were discussing how can we take PENAI to everybody, because not everyone, we are all a little lazy, and most of the time when we do obstetrics, by the time you come home, you don't want to do anything with the subject. You're so tired. You want to just spend your time with the family. In spite of that, our PENAI program took off very well. And then we were just discussing how do we take it further. And Dr. Sushma came up with the project. Of course, Dr. Sushma and Dr. Revati has been brainstorming it. My job has been just to sit on the chair and nod my head whenever required. And both Sushma and Hema took it on their head. And this program, I'm sure, will go very well. Recently, I was in Ballari talking about it. And the Ballari Society, without batting an eyelid, said, okay, next is our turn. So we are going to have lots of programs coming up. So thank you, Dr. Sushma and Dr. Hema. And I'm very sure you will come up with many such brainstorming sessions. A regular academic session, anybody can do. But something to think out of the box and see how we can do things in a better way, comes from certain ideas only certain people have. So thank you very much for that. And I thank all our audience who have been there always with us. It is not just the number that is there with us on Zoom. This program is being live casted on the Facebook. Live transmission is going on. So all those of you who are across India listening to us, thank you for being with us. We hope that these programs will make at least a small change in the way you practice and help everyone. So thank you very much.
Thank you so much, sir. Now I take this opportunity to conclude the program for today with a vote of thanks. Sir has Sir has done my job a little more easy by thanking most of the people. But yeah, as invested in me, I would like to start off my thank you with the people who are on top of this program: Sir, Madam Sarosh Rana, Dr. Revti, Dr. Sushma Dev, Dr. Hema Priya, who all are making this program work, who are leading the light and showing the world that preeclampsia is something that we need to be very, very careful about, and the patient lives do matter. Little acts of medical care can go a long way in not just the pregnant mother's care, but also into the baby's care, and also bringing out to us the most recent, the most innovative things that are happening in the world of preeclampsia, like the biomarkers, like how postpartum monitoring matters in the world of preeclampsia. Next, I would like to thank the entire SHIELD team, Dr. Prachi, Mr. Zingade, Mr. Nishant, and Ms. Sahiti, who has been a great pillar of support for us in terms of circulating the information around, calling up the participants, delegates being addressed, making the Zoom meeting available. I thank you wholeheartedly for making this happen. I would like to extend my thanks to Rajgopal and Srikant. I'm not sure if anyone of you have met them or heard from them, but they are the people who speak to you as we are from the SFMI office. They would many a times not even tell their name because they are there in the background helping us, making up the charts, sending out invites, making sure that the WhatsApp messages are sent on time, making up the CVs on time and everything. It makes it work seamlessly because of their support. I would like to thank all our participants for today, especially the delegates, Dr. Hema Priya for her wonderful talk, the capsule, and all the four panelists of today. Dr. Jyoti, Dr. Ramni, Dr. Shaini, and Dr. Swati for their wonderful participation on our panel discussion, making it sound very easy, but making sure that the importance of postpartum care is very, very important in preeclampsia. Thank you, Dr. Sushma and Dr. Hema Priya, to make sure that our on-site programs is on track, and we would be starting off with the first on-site program from Mysore. Thank you for all the participants for your patient listening. Once again, thank you all for a great morning event.